Lot of evidence is pouring in, and my job is to find out whether the data supports its routine use. So what is the current concept on FFR? The presence of a coronary stenosis alone doesn't mean it is ischemia generated. There is always a complex relationship between the angiography and lesion severity and the coronary blood flow. It is not always a 1:1 relationship. And coronary angiogram, now it is well known that it is an imperfect investigation to predict the outcome. And we have coronary physiological indices, both resting as well as hyperemic indices. The resting indices like PD by PA or the IFR, as well as the hyperemic indices like the FFR. And the hyperemic indices are well validated, and I'll be talking only on the hyperemic index, that is FFR. And they are now considered to be the invasive standard to identify the ischemia generating lesion. So do we have real evidence to substantiate? One, can we defer revascularization in a physiologically insignificant lesion? So anatomically it may look significant, like a 60% lesion or a 70% lesion, and that is the one that which always gives a headache, whether to deal with it or not, whether we should go on medical therapy, whether we should revascularize it or not. Can we safely defer revascularization if it is physiologically insignificant? Then the corollary, if it is physiologically significant and but looks like only a borderline lesion, whether we should revascularize all these physiologically significant lesions, and are they going to derive any benefit out of this revascularization? And can FFR guided revascularization improve outcomes when compared with an angio guided revascularization? And should we aim only functionally complete revascularization rather than an anatomically complete one? So these are the questions to be answered with the evidence supporting. So I'll review the evidence both in the deferral as well as in the performance group. They will remind us the reference group, and those patients with a high FFR of more than 0.75 who have undergone PCI, who have undergone FFR will remain as the perform group. And this is the first randomized controlled trial with the longest follow-up. Now the 15-year follow-up data is available. If you look at the 5-year data, the defer group in which angioplasty was deferred and the performed group in which angioplasty was performed, there is a significant difference in the cardiac death and acute MI after 5 years. You can see the reference group, the event rate was 15.7, and in the defer group it was 3.3 and 7.9, almost double than that in the defer group. And patients free from the chest pain. If you look at the baseline 1 month early part, if you look at this, this is the reference group, there the anginal control was little bit better. But as the years go by, the other group catched up, and there was no significant difference in the angina-free period. If you look at the 15-year follow-up, this is the deferred group, this is the perform group, and this is the reference group. So perform group means physiologically insignificant, FFR of more than 0.75, but underwent revascularization. So there was no benefit. Not only there was no benefit, you can see, we believe that usually there will be, in the defer group, the target vessel lesion should progress. They will have more events. But here, the target vessel lesions was not much when compared to the group in which the angioplasty was performed in an physiologically insignificant lesion. Over the years, 15 years, 2.2% was the incidence of MI in the defer group. So what does the defer trial told us? No long-term benefits offered by PC of angiographically significant, but physiologically insignificant lesions in terms of prevention of myocardial infarction. No increase in the catch-up revascularization among the deferred group. And medical therapy provides excellent outcome in long-term management of functionally insignificant lesions. And functional significance of the lesion is the determinant of the future events. It is not the anatomy. The FAME study is randomization of stable with some amount of acute coronary syndrome. Acute coronary syndrome, that means unstable angina, and NSTEMI with a CK of less than 1,000 units, but not STEMI patients. So total of 1,005 patients. One group angiographically guided PCI, other group the FFR guided PCI. And what is the outcome? All the outcomes, death, MI, repeat revascularization, the major adverse cardiac events, almost 1/3 difference. There is a 30% reduction in the event rate in the FFR guided PCI when compared with the angio guided PCI. And at 1 year, you can see there is a 5.3% absolute difference between in the MACE-free survival between the two groups, the FFR guided and the angio guided PCI. Not only that, a significant reduction in the number of stents used. In the FFR guided, it was 1.9 per patient, and the other it is 2.7 per patient. So the number of stents have come down. At 2 years, the same result is was persisting. Death or MI significantly lesser. The myocardial infarction significantly lesser in the FFR guided PCI when compared to the angio guided PCI. And what happened to the deferred lesions in the FAME group? The deferred lesions in the FAME group, there was a very meager number of myocardial infarctions. A late myocardial infarction, that is the one thing that we worry about when you leave a lesion, especially a borderline lesion in a vessel, and a patient, especially a patient who is presenting with an ACS, whether this will lead on to future event rate, future myocardial infarction. But in the FAME study, they found that in the deferred lesions, when they developed a myocardial infarction, the deferred group, when they developed the FFR guided PCI, the deferred patients, 8 developed myocardial infarction due to a new lesion or a stent related issue, and only 1 out of 513 developed a late myocardial infarction in the deferred lesion. So that means deferred lesions, physiologically insignificant lesion the procedure can be deferred safely. And what is there with the FFR guided angioplasty in the unstable angina and non-ST elevation MI in the FAME group? That is 30% of the patient had either unstable angina or a non-ST elevation MI. If you look at, can see, this is the stable angina group, this is the unstable angina, FFR guided PCA in the unstable angina end STEMI, and this is the angio guided. So the survival free of major adverse cardiac events is much better in the FFR guided group. So in the stable angina as well as the unstable angina group, FFR guided PCA was found to be better in terms of the outcome. In the FAME2 stable CAD patients, here the difference is FFR positive patients, that means physiologically significant lesions, they were randomized into 2 groups. One group undergoing medical therapy, the second group optimal medical therapy with percutaneous coronary intervention. And they wanted to find out whether if you treat a physiologically significant lesion with medical therapy, whether it leads on to an increased event rate. So follow up at 1 month, 6 months, and every year up to 5 years. Can see the composite of death, MI or urgent revascularization was significantly lower in the revascularization group when compared to medical therapy in physiologically significant lesion. It's a significant difference. And 2 year, this difference was maintained. Medical therapy, higher event rate in those with physiologically significant lesion. And this benefit was driven basically by a reduction in the urgent revascularization. And another important observation is that it depends upon the severity of the lesion. As the FFR becomes more and more significant, FFR becomes less, the stenosis severity increases, the event rate increases. When the FFR goes down below 0.71, when it becomes 0.6, 0.7, 0.6, 0.5, the event rate is increasing. So this is the randomized control data. Are these the results obtained in the randomized control data replicated in the real life scenario? This is the Korean registry, the Asan Medical Registry. In Korea, in 2008, 1.8% was the penetration of the FFR, and by 2010 it became 58% penetration, and they looked at a comparison when they were doing routine FFR and when they were not doing FFR routinely. What's the difference? They found the difference is less number of angioplasties, less number of, for example, it was 2 vessel disease angiographically, then functionally the 2 vessel disease came down, so less intervention. So number of vessels treated, number of stents used came down significantly. And what they found that less vessels revascularized when a routine FFR strategy was utilized, and less peri-procedural myocardial infarction driven the reduction, the primary endpoint. So basically it was a procedure related events that was reduced, and points to the issue in the use of inappropriate use of the stents. The largest registry so far is the IRIS FFR registry. The IRIS FFR registry, they found the same thing. As the FFR comes down, the event rate increases. In the group with the borderline FFR, that is 0.75 to 0.8, in the FAME trials, they use the cutoff as 0.8. In the deferred trial, they use the cutoff as 0.75. So many of the people even now consider between 0.75 to 0.8, it could be a borderline. So what happens in the borderline lesions? So borderline lesions, when they evaluated, they found that medical therapy would be a reasonable and a safe strategy, because the myocardial infarction was more in the performed group, but the target vessel revascularization in the long run was more in the non-performed or deferred group. So they matched each other. So a careful selection of medical therapy, it seems to be a reasonable option in patients with the borderline FFR. So borderline FFR, you can safely defer revascularization in selected cases. Medical therapy would be a reasonable and a safe strategy, and revascularization then should be based on a careful clinical judgment. So what we have learned from IRIS registry is revascularization was associated with a better outcome in only those with an FFR of less than 0.75. It prohibits stent implantation without an objective evidence of ischemia. And routine use of FFR leads to an outcome benefit, and FFR is a physiological biomarker demonstrating a risk continuum. Now, this is all in stable coronary artery disease. What in FFR in ACS? We have data from the PRIME registry, the famous trial, Little Rock registry, the Dynamic 3 Primulti, and the Compare Acute in acute myocardial infarction. I'll go to the Little Rock registry because others too did not provide much data on the outcome. Long-term prognosis of the deferred acute coronary syndrome lesions based on non-ischemic fractional flow reserve. And when you compare the stable ischemic heart disease and the unstable disease, you can find there is a significant difference in the event rate with reference to the FFR. So FFR in the 0.75 to 0.8, significant event rate difference. This is the stable angina, this is the unstable acute coronary syndrome group. It's a significant difference in the event rate. So what we are using the cutoff of 0.8 is basically data derived from the stable ischemic heart disease that may not be applicable in the scenario of acute coronary syndrome. For example, if you see here FFR less than 0.84, acute coronary syndrome, 11.4% was the event rate, annualized event rate. Less than 0.81 if it is, this is the stable angina group, it is much, much less. And this was basically driven by a reduction in the revascularization. You can see it's basically a reduction in the revascularization. The Dynamic 3 Primulti also acute myocardial infarction, FFR guided PCI of complete revascularization, whether it was beneficial. There was a benefit in terms of the event rate. So what we have learned from these two trials confirm that in STEMI with multivessel disease, complete revascularization is better than an incomplete revascularization, and FFR may be used and is effective in this context. That is for a functionally complete revascularization. So evidence-based FFR utility in ACS. In acute STEMI, no FFR in the culprit lesion. In old infarction, FFR like in stable patients. In end-stage and unstable angina, high rate of reclassification for the for percutaneous coronary intervention, and FFR guided appears to be safe. And there is a caveat for the clear culprit lesions. In the non-culprit STEMI and the end-STEMI ACS, FFR is reliable even during the acute phase, and it seems to be clinically useful, but it needs more randomized data for a confirmation. So, should we use FFR routinely as per the current data or current evidence? Definitely yes, in stable ischemic heart disease. And a little reservation in culprit vessels in unstable angina and end-STEMI where we need more data on it, and the data is evolving with the newer data coming up with the FAME3 and all. And probably you may utilize it in non-culprit vessels in STEMI with the two data that is available.